Hello, I'm Jonathan Kay, reporting from ACR Convergence 2025 in Chicago. I'm here with Joel Kremer, who is president of the Corona Research Foundation, who's done amazing work from that registry. And at ACR Convergence 2025, he presented poster number 449, looking at the cutoff for CDAI low disease activity. Now, the CDAI was validated against the DAS28 ESR and CRP, and levels of disease activity, low, moderate, and high disease activity, as well as remission, were developed with cutoffs comparing it to the DAS28. The cutoff for CDAI low disease activity is 10, and that is a target for treat to target. Now, the question comes up, is that low enough? And you looked at the outcomes of patients from the Corona Registry who had CDAIs of 10 or less, and what did you find?
Well, thank you, John. Thanks for that introduction. I first want to say that we use about 7,000 patients across more than 100 sites, academic and private, multi-specialty, etc. So we think we have a good representation of what's happening in the U.S. And the whole idea for this study was spurred by a study that was presented last year at this meeting by Mike Weinblatt using the BRASS registry. And the BRASS registry, which is Tertiary Healthcare Center, of course, at the Brigham, found that there were indeed differences in outcomes between patients in so-called low disease activity, between a score of 2.8 and 6 versus 6 and 10. So we wanted to replicate that in a very large registry. What we found that indeed there are dramatic differences when you look at baseline CDAI scores versus scores at 1 year and 2 year, starting different interventions. If you have what I'm calling very low disease activity, a CDAI between 2.8 and 6, your likelihood of remaining in LDA at 1 and 2 years is 14%. If, however, you have a baseline CDAI of between 6 and 10, your likelihood of remaining in LDA at 1 and 2 years is about 1/3.
Now, how does the change in therapy that is initiated based upon the CDAI score, how does that impact the outcome? Are people
That's a very good question. We looked across all interventions in thousands of patients, validating the legitimacy of a CDAI across different interventions. So it really begs the question as to what should our targets be. I mean, remission is great, 2.8 or less, but not everybody can do a remission. So if you have a CDAI score between 2.8 and 6, that's better. Turns out to be infinitely better for this lifelong disease than between 6 and 10. So why are we creating an LDA between 2.8? Why are we saying it's monolithic? It's LDA. And we should be making, I believe, treatment decisions, whether we change or add treatments, based upon LDA scores that are 2.8 versus 6, and of course remission, versus 6 to 10. There's just not a stable low disease.
So as a practicing rheumatologist, calculating a score isn't that hard, but it takes a little bit of time. But in clinical practice, a score and a CDAI of 6, if you had a patient global and a provider global of 0, would be no more than 6 swollen or 3 swollen and 3 swollen, 3 tender joints. So you want to make sure that you have fewer than 3 swollen and tender joints. So that in and of itself is a good outcome measure to target.
Yes, that's a good point. But you can also look at patient and physician and global. So if you're at a 2 on a 10-point scale, and you're at a 2 patient and physician global, that's 4. And you're at 2 tender and 2 swollen, now you're at 8. So your CDAI score in that individual is an 8. Is that good enough to treat this disease? Is a fasting glucose of 133 good enough. So we're drilling down a bit, and we're finding, and again, reproducing what was originally reported in Brass by Michael Weinblatt, that there are indeed significant implications of lower LDA scores versus higher LDA scores that we believe should be associated with decision making, how aggressively we treat these people.
So in your analysis of the patients with CDAI scores of less than 6, how many of them had one or no swollen and tender joints?
Well, you're asking a very good question. We have not yet broken down the components of the CDAI. We will do that. And I think it's a very legitimate question. And it's a question I've parenthetically been very interested in. But I think you got to do a metric. And there's all kinds of metrics. But tender and swollen joints, physician and patient global, do a CDAI.
Right.
If you're in this category, think about what you're hearing from your patient. Think about what is a legitimate metric for measuring disease activity, and what is a perhaps more shaky metric with the implications for accelerating treatment.
So as a rheumatologist, when I'm seeing a patient, I try to get it so that the patient has no swollen and tender joints, and if I can't achieve that, I will settle for one swollen and tender joint, and that pretty much is going to be a very low disease activity patient. So in clinical practice, one could already start applying the finding from your poster, your study, by aiming for that.
Yes. Well, thank you. We're writing up the manuscript. Hope to have it submitted by year end. We've been doing things the same way for so long that in many areas of human activity, it's difficult to accept and embrace a more refined manner of looking at any outcome. And that's just human nature. But so you need evidence. And this is a very large number of a very heterogeneous group of practices. So I think it would be nice to see this performed in a European registry. The difference is in Europe, of course, they use far fewer B and TSD modes. So these findings are particularly germane to a U.S. population, because the Europeans, they have cutoffs. You're not eligible in the UK unless you have a DAS. I believe it's 5.1. So these findings should be confirmed in European populations or Far Eastern populations. But I think for a U.S. registry, it'd be very difficult to have similar findings because there's no big registry that collects these kinds of metrics other than what we do in the Corona Research Foundation.
Well, this is yet another example of very important findings coming out of the Corona Registry with major implications for practice. So when you're seeing a patient with rheumatoid arthritis, aiming for low disease activity, aim for very low disease activity, CDAI of no more than 6, try to get it down to 0 swollen and tender joints, or at most 1 swollen and tender joint. And Joel, thank you very much for not only talking to me about this study, but the important findings that you're presenting.
Thank you very much. Pleasure.
I'm Jonathan Kay, here from ACR Convergence 2025 in Chicago. For more on this and other topics from this meeting and elsewhere, go to rheumnow.com.